1 year, dozens of innovations, countless ways to live better. Today, we're celebrating the 1 year anniversary of the Innovative Aging podcast. Over the last 12 months, it's been an absolute blast sharing game changing ideas that make aging in place not just possible, but exciting. Together, we've explored everything from beautiful grab bars that people actually want in their homes to non Wi Fi superpower rings and even NASA inspired balance scales. When I started this a year ago, my goal was simple: just get people excited about what technology can do for us and spark new ideas on how we can tackle everyday challenges with a completely different mindset. But as we kick off season 2, I want to look closer at what it actually takes to bring these innovations home and the real barriers families face, like budget constraints, family support, and tech readiness. Which brings us to a topic that sits at the center of every single conversation in healthcare, even if we hate to admit it, and that is money. Look, I know talking about finances can feel uncomfortable, and you might be thinking, what does money have to do with this? And my answer is that it matters a lot. Because I could have 100 ideas on how to solve a problem, but if a client hasn't planned ahead financially, my 100 ideas are now down to 5, and 3 of them probably involve duct tape. So, as clinicians on the ground, we face this harsh reality every day. Families don't just need a list of products, they need our guidance on how to pay for them and how to do a realistic cost benefit analysis. Ultimately, they need help deciding what will give them the absolute most benefit for the precious time they have to use it. So, where can we go to find resources that can support our clients? To help us break down the funding landscape, I've brought on 2 brilliant occupational therapists from different corners of the country. I'm incredibly excited to welcome Dawn Heiderscheidt, founder of Aurora Independence, and Sydney Marshman, founder of Happy at Home Consulting. Welcome to Innovative Aging, a podcast for clinicians who want to stay creative, stay informed, and stay connected to what's possible. I'm your host, Carol Chiang, an occupational therapist with 27 years of experience in rehab and home-based care. I know how hard clinicians work to keep their clients aging safely, whether that means hacking together solutions, testing new products, or thinking 3 steps ahead. If you're passionate about helping your clients function better, but just don't have the time to keep up with all the latest solutions, this podcast is for you. On Innovative Aging, you'll hear practical, energizing conversations with experts in rehab, design, and innovation that can spark fresh ideas you can bring back to the people you serve. Together, we can rethink what it means to age well at home and lead the way in shaping the future of aging. Let's dive in. Welcome to the show, ladies.
Thank you so much for having us.
Yeah, thanks for having us. It's going to be fun.
Fun. All right, so let's start off with a quick introduction. Dawn, let's start with you. Just tell us a little bit about your professional journey, how you got started in this field.
Absolutely. So I've been an OT for over a decade and recently had started this business about 6 years ago. And I realized, maybe not at the time that I started it, but definitely when I'm looking back on my journey, that this was kind of always the path I was going to go on. I was actually a childhood caregiver myself. So I ended up caring for my parents while I was a child. I was navigating aging in place when my parents were older and I was still in high school and college and all of that. And it really made me realize that I wish I had known what I'm actually able to impart on my clients now. And so, at one point, the COVID pandemic hit. We just, who's going to do what? Where are we going to go? And who's going to hire me? Because I had kind of gone from per diem into something else. And I realized that I just needed to create my own value. I needed to offer value to clients who are now stuck at home and the changing landscape of people wanting to stay in their houses as long as possible and actually helping them implement doing it. So that's kind of how I got started with Aurora Independence. And it's been almost 6 years now. So it's exciting.
Amazing. That's amazing. All right, Sydney, it's your turn. Give us your information about how you got into this field.
It's funny to be going second to Dawn because I feel like our timelines are so similar. But I have not been an OT for decades. I've only been an OT since 2019 when I graduated. And I had a brief blip in what I would say is traditional OT practice. And I realized that kind of like what Don said, I maybe was just destined to be here at this time, this place. But I was working as a traditional OT, and I found that the same struggles that we had in our family were what families were coming to me with, these day-to-day questions of how do I care for my loved one? What devices do I need? How do I get them home from the nursing home into back into their daily routines? What services and supports can we set up to make that transition successful?
Yeah. I think that that is the essence of OT, isn't it? It's really the real life situation. So if people are asking you for it, we need to be using our OT brains and figuring that out. So it brings me a little bit to the research. We know data. We know the data is there to prove these home modifications prevent falls. But, clinicians, we are still carrying that burden of convincing families to act now instead of waiting for that crisis. So I'm curious about what your experience has been. Like when families are hesitant about this cost and the necessity of these changes that we're recommending, what specific research or cost benefit data do you use to help them see that true return and see the value of what you're suggesting? Dawn, can you get us started on this?
Yeah. So, I mean, I think that's a really good question because sometimes the people don't care about the research, but then we know it's in our background. So, I think this is an excellent question on how do we kind of use that research to help inform it. And so, one of the research pieces that I kind of keep track of is there was a 2021 paper that kind of really examined it directly. It noted that falls cost over $50 billion a year. And that's with a B, not an M. That's a B. So $50 billion. And Medicare and Medicaid tend to take the brunt of handling that. And so that's really significant. And so when we think about whether or not this kind of is cost effective for families, you're looking at how expensive a fall is for society and for healthcare and for a family. And then you're kind of weighing that against like $100 in materials for doors, right? And so, yes, not all modifications are only $100, but when you're thinking about that benefit of, listen, we can reduce that $50 billion cost if we just spend a couple $1,000s here. And so sometimes my clients, if I'm reading the room, they're open to hearing that. A lot of the times I'm just trying to explain to them in their more micro system of, hey, you've got some dollars. Let's make sure the dollars that you're spending are the dollars you actually need to. So that tends to be my approach of knowing the research, but I don't always share it directly with families, believe it or not.
Right. We just keep it in the back of our minds and use it to kind of guide that conversation depending on
Exactly.
what's important to them, right? How about you,
Exactly.
Sydney? What kind of situations have you found that works in?
Yeah, I mean, I think similar to Don, just research informs practice, and I will never be able to quote research and what paper was published when and what are the dollar amounts. But I think when we're learning to be an OT, we start with this mindset of you need to think about discharge. Like from the minute that you meet someone, you need to think about discharge. And that's not that much different from when we meet someone in the home environment. And what is your long term goal with aging? Is your goal to stay here in your private home forever and ever? Okay, great. Then it does probably make sense for you to invest in your home and for us to explore grant programs and ways to keep you here. But if your goal is actually assisted living or independent living, even, then what is that little bit of it's not necessarily a break even point, but what is that dollar amount that once you need X piece of equipment or that the equipment is Y cost, then it's going to start that chain of events to have us start exploring moving to an assisted living. I try not to lead with safety, even though safety is so quoted in the research and is such a key piece because we're all worried about fall prevention and safety is such so tied up in that. Really try to focus on the endpoint, which is where do you envision yourself in 1 year, in 2 years, 5 years, 10 years? What is your long term plan?
Yeah. And I think, ultimately it's not necessarily the research that's important. It's that we're leaning on objective measures.
Hmm.
And you mentioned before about like that break even point, and I think that's an extremely valuable tool that clinicians can use to highlight that. And as an example, some people know that my father-in-law was recently put into memory care, and I remember having the discussion with my mother-in-law and I said, "Listen, I want you to go and look at these places before he gets really sick. Find out how much does it cost per month? How much does the one you like cost per month? You might the physical distance from the house may make that cost, a different value for you. And it was really good for her to see that and recognize, okay, 1 month is $7,500. And so she knows that if her home health care costs get to that amount,
Mhm.
factoring in what is the toll on her body, on her psyche, on her ability to have self-care time, that's where the break-even point is for her. And I think that providing a scale, something objective to hold on to, really helps our clients understand that. In addition to, hey, it's a real fact that we can decrease the falls through home modification. We can keep you at home. So I love all of those ideas. And, it's great because it's a great segue into the money part of this, which is this huge elephant in the room. So I want to start by stuff that people know a little bit about. So, Dawn, I know you have had experience working in the capable model.
Yeah.
And Sydney, you've been able to shift from capable to the HARP model, working with Area Agency on Aging and the local county public works. Can you both share with our listeners, how do these programs and others actually operate? And help us understand, what are the positive outcomes and the limitations that clinicians still face on the ground? Dawn, the mic is yours.
Absolutely. So, Capable, I think, is one of the programs, and I'm putting that in air quotes right now, that people are most familiar with because Capable is often very confusing for people. There is this misconception that it's this like national or government funded formal program that's something that you could just like apply to or get involved in. I have OTs who reach out to me all the time when they found out that I have run a Capable program before. But the reality is that it's just an evidence-based framework that has been like licensed by the Johns Hopkins School of Nursing. It's supported by research, and originally it was implemented in a very specific area through funding that Johns Hopkins had actually obtained, and now they have branched it out to other people who can purchase that licensing. So the key here is that somebody who wants to implement that capable program, they need to purchase the license to use this framework. And then there is a lot of support from the capable like network from the Johns Hopkins team that has grown into other things. But it's really up to the individual program to find the funding for it. And I think that's a piece that most people are not aware of because they think that there's just this national funding available for it. And so you kind of have to get creative in your local area where you may want to look for funding, who's going to fund it, what that's going to look like, how many years it's going to be, and things like that. And kind of to the previous topic, Capable and other programs, as I'm sure Sydney will get into, they're all trying to answer that question of like, do we modify? Do we move? Do we stay safe? Do we implement this? And do we add all that kind of in there? So Capable was a lot of fun, but yeah, we ran out of funding, and so it was usually a limited program due to the funding costs.
Yeah, that this is incredibly clarifying, because I
Mhm.
think it is a misconception thinking that you just apply for a capable position, not
Yeah.
understanding that capable is a framework, a lot
Yes.
like an architect would give you plans to the house, but it's up to you to organize all the people who are going to build it and all the pieces that go with it. So there's a lot of managing in this.
Mhm.
And it's really kind of up to whoever is going to run this program to find the funding, find all the pieces, and then get it running. So
Yep.
thank
Get
you
all the
for
administration staff, all of that. It's hard. Mhm.
Yeah, it sounds like a lot of work, but at least, through that work, that they have had research to show that there
Correct.
is impact. So we're not doing it for nothing, but just recognizing that this is work. But,
Mhm.
if you can find the funding and you can find the right partners, it could be a great program for you.
Exactly.
So, Sydney, can you tell us a little bit about what you've been doing with how your programs work?
Yeah, so we also ran a capable program, and similar to Dawn, our funding did just naturally expire over time.
Mhm.
And something that we noticed when we were running capable is that a lot of the referrals that we were receiving for the capable program, which I should note was kind of around the COVID era, so take that with an asterisk, that practice was just different then,
Mhm.
is that people already had nursing involvement. Capable involves nursing. Capable was also really expensive for us to run. Because of that framework, there's some benchmarks that you have to meet as far as how many visits people um, ac- actually finish, actually complete, how many months they're in the program. And all of those factors do increase the cost of the program. So we weren't able to find a partner that was able to take in those costs once the grant funding ran out, which is unfortunately something that happens with a lot of the evidence-based programs. So kind of how things naturally go in my life, I had signed up for a free falls prevention training that someone posted in a Facebook group. And lo and behold, I was certified to provide the HARP program. And I wasn't really sure what that meant. But the piece of that is that the reason that Capable can receive part of the funding is that it's on this special list, right? It's the Title 3D evidence-based programming list. And through the training that I did, they were still in the process of applying to be on that list. Once I had completed that training, they were then on the list to be able to receive federal funds through certain organizations. So we actually moved from our funding expiring for Capable and saying, gosh, we need folks to actually complete the program. A lot of people fell off at like the 3 visit mark, and they already had a nurse, so they really didn't want to see our Capable nurse. And we switched over to providing HARP, which is 1 to 3 occupational therapy visits. And we pair it with an equipment budget. We've worked that out through the organizations that we work with. And it's been a really great starting place. This has been years at this point. But it's been interesting to see how the different organizations use that similar framework, and how they've been able to braid it with their funding, because their funding is slightly different.
And before we move on, let's just in case anybody has not heard of Capable and how that runs, can you
Yeah.
give us the differences between the HARP and Capable, or if there are any differences in there?
Sydney,
Dawn,
I'll
you're
let
our
you take that.
Capable. Oh,
I was gonna say,
geez.
I'll let you take that one because you've done both, and I have only done the capable.
Okay, well, I believe Capable is 6 OT visits and 4 nursing visits, and I believe it's supposed to be completed in 4 to 6 months. Is that right, Dawn?
Yeah, and I think they have to complete at least 80% of the visit, so
Yeah.
it can be a mismatch of the OT and RN, but it needs to be at least 80%.
Yes, and that was one of the things that we were running into, is that people would start the program and then they would fall off and say not fall. They would elect not to continue with the program. So then when we're reporting back our outcomes, we couldn't count those people as completers,
Mhm.
even though they had received services, they had received equipment, they've been connected with resources, yet they didn't finish the program because of the fidelity measures. HARP, on the other hand, is 1 to 3 visits over about a month. Unfortunately, it doesn't always take about a month for our team. Sometimes it takes longer because we have a really large rural service area. But it's a very night and day difference.
Fascinating. Well,
Mhm.
what about nonprofits, like partnerships with nonprofits? Dawn, this is something that I think you know a little bit about. Can you talk about what those pros and cons are?
Absolutely. So, this is sort of the model that I started my home modification and home accessibility business with. And I think the key here is that all of the paperwork and administration side that we talked about with the programs like HARP and Capable also still kind of apply to these nonprofits. So, the paperwork issues are just different because now you're trying to have two different organizations potentially. Uh, Kind of try to merge their systems together. So I was an independent business coming into a nonprofit. And the other piece of this is that the funding isn't universal. So very similar to the funding for HARP and Capable, you get a certain type of grant for a certain number of years to hit a certain number of houses, and that's not guaranteed that you'll get that again. And so even within the partnerships for nonprofits, it's not necessarily like a set it and forget it situation, because the funding does impact it. And What's really hard is that the funding is impacted from a federal level. So, who your electors are in your state, in your city, and obviously at a federal level as well, all impact because it kind of funnels down to the states, the counties, the townships. And nonprofits, which is a thing that most people don't realize, is some of those national nonprofits that we all know the names of, each individual chapter actually runs kind of on its own. So while they're getting support from the national affiliation, the reality is each chapter may have different goals, missions, and things that they are trying to provide to their local community because ultimately they're trying to serve the community in front of them. Essentially, this means that like OT well, let's be honest, biased OT always fits in there, but the organization or the chapter may not necessarily see that at the time. So, working as a partnership with a nonprofit is a great place to try. It is not the end all be all. There are absolutely some pros and there are absolutely some cons to it. And so, it's just a matter of making sure that you're thinking about who you're trying to serve, who's in your area, and how realistic that actually is.
Yeah, and it sounds like, it's twofold. It's a funding problem, potential funding problem, because you never know when it might end or be renewed, but it's also a leadership issue where you don't know who's actually
Correct.
leading that particular chapter in what location, and do they know what OT is? Do they value OT? And I think it really comes down to us becoming very good at being able to advocate for, like, what is the value that OT brings and how can we help? And
Yeah.
I think we all end up having to be a little bit of an entrepreneur. Even if you don't own your own business,
Correct.
you need to be able to communicate all of these things and showcase that. I think it's really interesting. I was talking to some researchers recently who said that they felt like entrepreneurs, that they are
Mhm.
frequently chasing funds all the time, right? To fund their research. And how do you chase those funds? You have to be really good and clear about pitching your idea and showing that you know what you're talking about and this is worth a shot. And
Yeah.
I
And you
I
need
feel like that's a great example for us to follow.
Exactly, because you need the champion in the organization to kinda talk about you when you're not at
Mhm.
the meetings that they may be at, and so that's a piece that I don't think people pay attention to. They may see how successful someone else is, but they don't realize that, like, some of this is luck and some of it's just finding that champion and getting them on board because then they'll fight for you within the organization.
Right. Yeah, it's
Right.
it's
And
definitely a very lucky thing when you find somebody who loves OT.
Mhm.
I love that, and I love finding our champions of OT, and I want to add to that that sometimes we have to be our own champion,
Yes,
and that
yes.
nonprofits generally are run by a board, and it's a great time to look into what it means to have a board position.
Mhm.
And yes,
Mm.
unpaid hard work, but it's a way to get your name out there and also continue doing the work that you really love and looking for a path forward for the people that we love to serve.
Absolutely.
And a way to elevate our profession from the inside,
Mhm.
you know?
Yep.
Yeah, I love this. So, I want to talk about some other reimbursement models. I mean, we could be here all day with all the different tiny little versions and stuff, but I just want to be able to give people at least a decent idea of, what's out there and then what's available as we talk through like the different income levels as well. So, Sydney, I know that when you encounter clients that are stuck in that coverage gap, the ones where they're just barely over that cutoff to qualify for federally funded programs, like, how does your company offer guidance and creative funding solutions to help them make these home safety changes a reality?
Yeah, I mean, we are a Medicare credentialed practice, so that provides a starting place. But we are not a network with any of the Medicare Advantage plans. That has posed a lot of sticky billing issues of looking at how do we scale and how do we grow our business. So, actually, what we've been able to do is we've been able to partner with other organizations that are in network, and we've been able to coordinate with them on how do we get people served and how do we get them connected to resources that are within reach. And part of that is making sure that we have insurance coverage for some of those conversations. But when we're talking about these like bigger home modification projects and the programs that we're doing, it really depends on which program, because right now, in the two that we've kind of talked about today, One of them has federal funds that are direct from the federal government. The other one is like federal pass-through funds. I'm not the expert at that, but my understanding is that the federal direct funds, they have pretty strict income requirements. So they have to meet certain incomes. Otherwise, the person just does not qualify. The other program, though, has a little bit more flexibility because my understanding is that the federal funds flow to the state before they come to the organization. So they have a little bit more flexibility. And for that reason, they don't, they call it means testing, I believe, that they don't have an income requirement. So that provides a great opportunity for people to engage in our programs, even if they fall within the gap of not being able to qualify based on income. But we talk about that kind of group of middle folks with about the same things that our high income earners already know, which is how do you situate your financial pictures to be able to qualify for Medicaid and to be able to qualify for federal programs or state programs to help you age in place. And unfortunately, there is often a attorney fee with that, and it can be expensive. But again, we're looking at the long-term goal. So if you want to age at home, you may need Medicaid. Or if you want to go into assisted living, you also might need Medicaid. So it's not always the topic, but it's a very frequent topic of what does the long-term planning look like financially.
Mhm. Yeah, these are tricky questions. And I think about a lot of the clients that you get in home health, and those tend to be that upper middle class ones that make way too much money for any kind of assistance, but they're not filthy rich in order to just say, well, we're just going to like knock this whole thing down and start over. So, Dawn, I know you have a little bit of experience in this. Can you share with us what your solutions have been?
Yeah, absolutely. I mean, I think similar to what Sydney is saying is that it's about being really creative and understanding what options exist out there for the individuals who are looking for it. So, this is where you have to be knowledgeable about what options exist in your state, your local area, and kind of become the expert in that micro area, right? And so the other piece of this is using and depending on any type of the other professionals that might be already in your circle. So as Sydney mentioned, you may need an attorney. It might be worth, connecting with your financial advisor. It's looking at what your home equity could do for you and whether or not that actually makes sense for your current situation. And so we're trying to figure out if you have long-term care insurance, what types of benefits are available in there, how do you access those types of benefits? And then ultimately, if somebody needs to age in place or is looking to do that and doesn't have the funds, what's really great is us rehab professionals are really knowledgeable on how to modify something so we can change how we achieve that aging in place process. Maybe it's not a luxury remodel that's, a $100,000 bathroom, but that doesn't mean we still can't get you something that is functional, potentially aesthetically pleasing, and still very much going to help you hit whatever your current goal is. And so it's really, really important to start thinking about those different creative solutions. There is always fundraising, but this is where I do want to caution people. If you happen to be in the lower middle class or you're on those cusps or anything like that, some of those fundraising funds can actually count as income and can hurt your income eligibility for certain programs. And so, looking into nonprofits that help you potentially fundraise without it actually counting as income for yourself is also really important. And so, while we as rehab professionals don't know everything, it is important for us to understand the ecosystem in which this exists so that we can help guide clients or maybe be the person who helps them be aware that, hey, there could be a limitation here. Be creative, but also understand what that creativity means for impact.
Yeah, these are all really good points. And I think what I'm hearing also is, clinicians are good at patching together solutions when necessary. And while that's awesome, I still also believe that our end goal as clinicians is to educate what is out there, to prepare in advance so that you have the money to afford something a little bit nicer. And, my favorite conversation with clients is look at all this cool stuff. So when you go to do your routine remodel, let's think about putting in backing in the walls and start your preparations early. Do them decades before so you can enjoy them, but also that you don't have to think about this giant amount of money all at once. So, Sydney, speaking about talking about all these alternatives, I want you to tell us a little bit more about the advice that you gave in the Good, Better, Best navigating home modifications across all income levels that you talked at AOTA about this year.
Yeah, I mean, I think it's so similar to what we've been talking about today, right? Which is that we need to talk about money more. Money impacts everything for us as practitioners, for the people that we serve, for the programs that we work with, all of the pieces. And I think we've done ourselves as occupational therapists a little bit of a disservice. We provide some really straightforward solutions that do work for most, if not all, people. A tub transfer bench is a great example. It works for a lot of people, is a great solution. But when we're talking about these longer, bigger goals of like how to qualify for Medicaid in the future, especially if you're on the cusp, like why wouldn't we talk about a larger remodel? Why wouldn't we talk about doing that spend down in a way that makes sense for you and your family, not just because you have to? So I think in some ways, the talk was a nice way to look at the different options. But the gist of the entire talk was build some comfortability around talking about money, understand what resources are in your community, understand how they impact the people that we work with or OT directly, which they probably do. Um, and start putting together the pieces because I think as you build that familiarity with the people and the network, you end up opening up more doors, even if you're just asking a question to either inform yourself or even on behalf of a client. It can really open up long term goals for you as a professional or your practice or whatever um, that is.
Yeah, you never know who you're going to meet when you start talking about these things. And it can be a really fascinating way to come up with an even more creative idea. Think these ideas didn't come from a textbook. These ideas came from lived experience and going out there and trying it and having conversations and seeing, okay, where can we do better, or who's got an idea for how we can get these things covered or whatever in there. So, Dawn, like I know you've had a lot of experience doing both ends of this spectrum, like the really low income and the private pay home, like whole bath remodels. So, when you look at it from a clinical perspective, what do you feel like are the changes that give clients the biggest bang for their buck?
Yeah, absolutely. I mean, when I look at it, I kind of look at the whole house and I was thinking about, where is the biggest impact? And for me, it's railings, believe it or not. Like I know a lot of rehab professionals immediately talk about rugs, but that is just not a fight I'll get in personally. I don't care like about your rug. I care about your stairs. I care about your railings. And believe it or not, in my area, it is one of the biggest pushback points, even more so than rugs. And I think it's because we live in a housing stock here in the Northeast. I'm in Philadelphia, greater Philadelphia area. These houses are a couple hundred years old, so they're not to code. Their steps are sometimes more like a ladder, and so people have this like concern about being able to carry something up at this like undetermined time that they're going to clearly be carrying things up and down the staircase, and so they don't want railings because the railings are going to cut into that. But I'm not going to lie, it is the number one thing that once people kind of install it, and when I do my post occupancy check and I check in on them a couple months later, they're like, "Why did I fight you so hard on that? This thing has been life changing." And I'm like, "I know. Thank you." So it kind of always cracks me up that that's one of the biggest pushback items. And then one of the unsuspecting items are those tension based pole assists that exist and they run from floor to ceiling. I have a lot of therapists who are like concerned about the safety of them. And me too, Sydney, I bet you were a little concerned the first time you recommended them. But I'm not going to lie, I've had a few people design their new bathrooms around their pole so that they brought it in, even though they spent all this money. They were so excited to bring that pole back because it was something that they really loved. So they can hold a lot of lateral sway. They're actually pretty safe and it's excellent for renters too. So those are two of the highest impact items, I think. that I see
Okay,
personally.
I have to chime in on that because
Please
I think the
do.
railings thing is so funny. I also get a lot of pushback on railings, and it's always about, like, how narrow
Yes.
it like, the railings make it,
Yep.
even though it's still wider than, like, a front-wheeled walker, if that
Yep.
makes sense.
Yep. But
That
they've
I
got to
just
carry some washing machine upstairs apparently at some point.
Right, right. It's so interesting. It makes me feel like so I don't recommend, suction cup grab bars, but I do carry one for the purpose of showing people, like, this is where I'd put it, this is why, that I feel like I need, like, a temporary railing, like,
I
to
know.
just experience it for just a second. Also, my funny tension pull assist, bar was I ordered one for one client, and I went to go install it. And I walked in her house, and I looked at her, I'm like, "Oh my gosh, drop ceilings.
Oh, I
Cannot
hate that.
install
You
a
can't.
tension-based pull at a drop ceiling," and I just completely
Such a
forgot to look
bummer.
at it. Such a bummer, such a bummer. So we found a new solution, but it was just one of those, like, "Gosh, how did I miss that?"
This is why we didn't talk about this, but anybody watching, this is why you take photos, right? So sometimes I
Yes.
use my photos to go back and I'm like, oh, just kidding. There's a window there or those drop ceilings.
Yeah.
You're like, is that popcorn ceiling? That also won't work.
Yeah, well, it will, but it'll come off with your pole. Yeah,
Valid. Yes.
yeah,
Yeah, not ideal situations. Yeah, every house
yeah.
is a little bit different, so you're having a plan for all this. This is exactly the conversation when people text you and say, "Hey, like what's the best X, Y, and Z for this situation?" And I'm thinking, "Oh my gosh, it depends on so many things, on the
So many
So
things.
many
person, the
variables.
space." Yes, you
Mhm.
have to try to have a conversation with an OT who can help walk you through all of those brain part decisions to get to the right answer.
Mhm.
So we are starting to run out of time, but I definitely want to get to have you guys share a little bit of a case study. I want you to help people understand like how do these home modifications improve lives and like how does it keep people in the homes that they really love? Dawn, let's start with you.
Yeah, absolutely. So, one of my favorite case studies that was one of those ones that started about mid career, and I kind of was starting to feel really confident, but not like fully confident yet in everything that I was doing with home mods. And I had a family who reached out to me. Their home, again, was built in the 1700s. I mean, this is literally like 18-inch thick stone with stucco and all of that. And they had me out there to try and help guide them in how to best support their loved one who had metastatic cancer. They knew that hospice was probably going to be the route, and they really wanted him to be able to age in place. They wanted him to pass away in the home. The family was really close knit. I just like immediately loved them. You know how you walk in and you're just like, oh, you're my family, right? And so, using therapeutic use of self, I kind of walked through that house and I looked at their property and I realized, well, you guys are lucky enough to have this like pool house. Why would we spend all this time and energy and money trying to modify this home from the 1700s, literally, when we could modify this newer structure that's just a little bit easier and almost probably for the same amount of dollars? Because we were thinking about adding a first floor bathroom to this home. It would have involved running plumbing. Pool house already had it. You know, it just kind of worked out. And so the family has admitted to me afterwards. So unfortunately, their loved one has passed away, but they were like, Dawn, we're so grateful that you really pushed me and pushed us to do that. Because in the end, they realized there was a lot of dignity that allowed them to love their loved one in the space that actually worked for the family. Turns out it's going to be the accessory dwelling unit for the spouse who has left. Children are moving into the home from the 1700s. She's moving into that ADU, and then kind of allows the family to all come together. It was one of those ones where they were about to spend like a lot of dollars though. And I even told them after I gave them my recommendations, I was like, I think we're ready, but I'm so nervous that we missed something. And yeah, we probably always will, but the family was really happy about it. So that's one of my like beautiful case studies that just, mwah, chef's kiss was perfect.
I think we play such a big role, clinicians play such a big role in this guidance piece in it, and
Hmm.
I can honestly remember times where somebody has just texted me and said, "We're gonna be okay, right?"
Yeah,
Like, "Okay, they're gonna start the demo right now, we're gonna be okay, right?" I'm like, "Yes." Our job is to reassure and provide confidence that, yes, you are making the right choice and you will love the result later, and so don't worry.
exactly.
Sydney, I'm sure you have a similar story to this. Please share with us.
I don't know. I don't have the ADU story. Okay, for as long as we've been friends, I haven't heard that story
Oh,
unless I forgot
really?
it.
Oh.
Yeah, I love that. I love that. Well, I don't know if I necessarily have like a specific story, but one of my things I've been reflecting on lately is I am most definitely like eldest daughter. Those are those are my vibes. They always have, always will be. And I have always been just gosh, my mom has always been the person that people went to for, like, medical advice, like, she's a nurse, she always and she's also very opinionated. So, she has always been the person that people go to when things happen, when someone gets cancer, when someone has a surgery, when life just inevitably happens, and it's been so interesting talking about, like, finding your champion of OT to find that, like, that person's actually been my mom, and
Aw.
not in, like, the "Oh, my daughter is an OT," that's nice, but when those people call her and say, like, "Hey, Linda, we're, like, starting a bathroom remodel," and she's like, "Do you know this is, like, what Sydney does? Like, this is her job." They're like, "No, I had no idea." We yeah, like, she can definitely come over and look and, see, if she has any thoughts, and they kind of do it, they offer those opportunities not as a thing for them, but as a thing for me, as
Mhm.
a learning opportunity. I don't wanna quite say pity, but, like, they're just supportive of my learning, and then all of a sudden, we'll finish our visit, and they're like, "Wow, this was actually super helpful." Like,
Like,
weird.
their preconceived notions are just blown out of the water by your
Blown out
amazing
of the
abilities.
yeah, yeah, and it's like, yeah, it's, like, almost like I do this every day. Crazy.
Let's do a lot more of that then. Let's blow people out of the water. I think that's the ideal
Yeah.
thing. You just have to get your foot in the door, just convince somebody, just let me come, let me just take a look. And I think inevitably, really, people always leave and think, whoa, like I learned so much from that person. And maybe it's just they had no expectations, but I would love to
Mhm.
see that change in our profession, that we don't always have to get lucky that somebody says, yes, sure, you can
Yeah.
come and let me blow you away. It can just be, listen, we know that you guys have superpowers that we cannot see and we need your help. Please come visit us. So,
Yeah, and then freaking own it, right? Like, own the
Yes.
fact that you're an occupational therapist, an occupational therapy practitioner, and share it.
mhm.
Yep,
Yes, we
yep,
are
I love that.
professional problem solvers, as I always say. Okay, such an incredibly valuable conversation. It is time for takeaways. So, what would you say your top 3 takeaways are, Sydney?
So, my top 3 takeaways, I think first and foremost are I know that this podcast is for, more than just OTs, but I'm sorry, I'm so biased, and home mods are a learnable skill, but for OT practitioners, they are innate. It
Mhm,
comes so much easier to how our brains are wired and how we are trained, um, to go through the home mods process with clients. So I would definitely encourage OTPs to own that and to really continue to show up as the home modification expert. And to add on to that, the research also shows that. Like, that's one of
mhm,
the core tenets of the home modifications research is that OT involvement is so important and does affect outcomes.
mhm,
My other 2 that was a long-winded first one. My other 2 is, similar to, like, our talk around the community and, like, the ecosystem of aging, is that, yes, we are great at providing product recommendations and providing solutions. I love your duct tape comment, that's freaking hilarious. But it's also understanding, like, who are the other players in the ecosystem? What are the other referrals I should be making? Because at the end of the day, it's not gonna be the tub transfer bench that keeps someone at home. It's all of the factors that come together to provide solutions for that person over time, and over time when you are no longer working with them. Therapy is not designed to be a long-term support, it's designed to be consultative. So I think we really need to set up our patients to succeed in that model. And then
right,
going back to, being a board member and, like, being involved, I think it's so important for occupational therapy practitioners to be paid what they're worth. And I think that we are worth our weight in gold. But I really, really want to highlight that the learning that needs to happen around this work is not going to happen in your day to day. It's probably not going to happen in a specific certification. It's probably not even going to happen at the end of this like continuing ed episode, right? You need to really be intentional about how you build your understanding and the work that needs to be done to grow your understanding. And a lot of that is unpaid time and effort. And it is a hustle that is unmatched, and it's not in the day to day 9 to 5 hospital job, home health therapist. It is a lot of it's a lot of intentional effort to grow your network and to start talking about solutions and how we see the future of healthcare.
Yes.
That
Oh my
is
gosh. I'm
amazing. Yes.
like,
So, yes,
yes.
so true, right? Mind blowing.
I don't people can't see us, but like we can see each other on video and it's like nodding the head. It's like, how do you get that to make a sound on this? Because that is, yes,
Well, it'll
just
be on
all of that.
YouTube, Dawn. It'll be on YouTube. Don't
That's
worry.
true. That's true.
All right, Dawn, let's hear it. I want to hear your 3 takeaways.
Well, I don't know if mine are going to be as impactful as Sydney's, but I'm sure going to try. I think to kind of build off of Sydney's last one, I will kind of start with what I thought was going to be my last one. But to go with that, I mean, there is a lot of competition in these home modification and aging in place spaces. Architects, building interior designers, construction world has been doing this for a long time, and they haven't necessarily been doing it right all the time. So it's really important to understand that we coming in and saying we're amazing is not enough because we are not who people are thinking of first place. So that hustle piece that Sydney was talking about is like 100% accurate. So like kudos. I think one of the other thing to add and build on that as a takeaway is that like no one's coming to that rehab professional to solve their problems. Most of the time, they don't even know that it's an option. That is, again, one of the feedback I get from clients all the time. They're like, I didn't even know that I could call someone to ask this question to when they're on Amazon looking at products, right? So we have to be loud. We have to be really proud of what we can bring while also breaking down any preconceived notions of what we do, and that includes inside of our own brains. Because I think a lot of OTs and a lot of rehab professionals, we kind of get stuck in that medical model and reimbursement model. But that is not where, especially OTs, that is not where we thrive. We only like 2 of our domains is covered by insurance. Everything else is like private pay, right? And so then the last one I want to leave people with is sort of about the client. And it's really important to understand that sometimes we are going to have to push people who don't want to be pushed, but we have to make sure that we don't come in as overbearing. We are a professional and we might know the better solutions for clients, but they really are the experts of their lived experience. And so that kind of goes back to earlier conversations of looking at the entire ecosystem, looking at the client, and making sure that while we have the knowledge, we don't just lecture, but we also make sure that the clients who need the push get the push that they need. And I think those are my 3 takeaways.
I love that. The experts in their own life. That is genius. And I feel like I have to mention something about that because I can remember always telling patients, I may know this, but I work for you. I'm not here to tell you anything. Okay.
Mhm.
I have knowledge that is at your disposal, and we are collaborative partners on this. My job is to ask really good questions so that I understand what's important to you, where you're coming from, what you're worried about, what your preferences are. And then you give me that mix. Those are my parameters to work inside. And my job is to figure out how do you get that outcome, that goal that you're looking for within that zone. And I think that that's where that creativity blooms. There's no creativity when you have an unlimited budget. There's a whole lot of creativity when you're forced into those little sections in there.
Yeah.
So I love it. I want to just say that we can approach this like this challenge that is just awful, that we just would see solved with money. And then I could also say, you know what? Some of the best ideas come out because of those hardships. So can we have a balance of both of these things? I would love to see that. That's the attitude I would hope that clinicians will leave this episode with. So I would love it if you could share how people could reach you guys if they want to learn more or they want to follow you, have more questions. Sydney?
You can almost always find me on LinkedIn. I am an avid LinkedIner. It's probably the only thing I do consistently. I am on Facebook and Instagram. You can message me there. I will respond at some point, just probably not promptly. And the content you see there is sometimes up to date and sometimes not. But LinkedIn is always up to date and I'm always accessible there. So I would start there for sure. And if you're not on LinkedIn, get on LinkedIn and start sharing the great work that you're doing.
100%. That's right. Be on LinkedIn. All right, Dawn.
Yeah, I mean, I'm going to just re-solidify that because the only place I really exist right now is LinkedIn. I technically have a Instagram, but like it's kind of for the business. And I realize that my clients aren't on Instagram finding me. So it kind of died. For the most part, though, I'm not on socials as much as I used to. I used to be on a lot more. And lately I have just been like hyper focused on my area and just trying to grow the business and serve the clients that are in front of me. But LinkedIn, I'm going to go with the theme, is probably the best place to get a hold of me.
Yeah. And I think, honestly, it's the best thing to have all of these OTPs that are on LinkedIn and showing up and showing and getting into these conversations and commenting. And to your point, Sydney, previously about getting involved, that's how you get involved. You watch what people are doing, you comment, you get to know people, you get on those Zoom meetings and see, like, how can I help you? How can my OT brain contribute to what it is that you're doing? Okay, we are out of time. So I want to extend a huge thank you to Dawn from Aurora Independence and Sydney at Happy at Home Consulting for sharing these incredible insights and practical takeaways. Thank you for tuning into this episode, and I hope to see you again all next time. Bye-bye. Thanks for tuning in to Innovative Aging by MedBridge. Be sure to subscribe on Spotify, Apple, your favorite podcast platform, or listen directly at medbridge.com. If you'd like to earn continuing education credit and access bonus resources from this episode, just log in to your MedBridge account and search for the show title to get started. And we'd love to hear from you. If there's a topic you want us to explore or a guest you'd love to hear from, reach out via Instagram or email us at podcasts@medbridge.com. Thank you for the work you do and for joining us as we explore what it truly means to age in place. See you next time.